Welcome! The following presentation from Answers in CME is part of an educational activity titled Survivorship Strategies for Patients on First-Line HER2-Positive Metastatic Breast Cancer Maintenance Therapies, Practical Guidance on Monitoring and Adverse Event Management. To access the full program and supporting materials and to claim your certificate, please visit the activity URL in the episode description. This activity is supported by an educational grant from Pfizer Incorporated.
Hello, and welcome to this session entitled Survivorship Strategies for Patients on First-Line HER2-Positive Metastatic Breast Cancer Maintenance Therapies, a practical guidance on monitoring and AE management. My name is Dr. Bill Gradisher. I'm on the faculty at Northwestern University, and I'm joined by Jane Mizell, and I'll let her introduce herself.
Thanks so much. It's great to be here with you today, and I'm looking forward to the conversation. I'm on the faculty at Emory University in Atlanta, where I co-direct the breast medical oncology program.
Great. So these are my faculty disclosures, Dr. Mizell's. And these are the educational objectives, which were more or less outlined by the title of this session, which is looking at maintenance strategies and ways to mitigate some of the side effects that we see related to these strategies. And this is an activity supported by an educational grant from Pfizer. Answers in CME is accredited by the Accreditation Council for Continuing Medical Education to provide CME education for physicians, and Answers in CME designates this activity for a maximum of 0.5 AMA Category 1 credit, and physicians should claim only the credit commensurate with the extent of their participation in this activity. We want to draw your attention to the Q&A function within this platform. So you have an opportunity to ask questions, which we'll get to towards the end. And you can simply put your question into the chat, and we'll address anything that you're posing at the end of our comments. So let me start out things. And, I think just as a level setting starting point, we can say, how is first-line standard of care evolving in HER2-positive metastatic breast cancer? And I think everybody appreciates that in this setting, the Cleopatra regimen has reigned supreme for many years, more than a decade at this point. And if you sort of take that into account as a starting point on this slide, which summarizes some of the recent activity as well as trials that are ongoing, we have appreciated the activity of the Cleopatra regimen, which, as you know, is a taxane with dual HER2 targeting, followed by HP, assuming patients are responding, usually after 6 to 8 cycles. And that dual targeting strategy was demonstrated to improve median PFS as well as overall survival. And then more recently, we've seen the introduction of other antibody drug conjugates into the treatment of HER2-positive breast cancer, including TDXD or trastuzumab deruxtecan. And the recently presented DB09 trial looked at that strategy of TDXD plus P in metastatic disease without a break, just simply continuing it. And in that circumstance, the PFS was demonstrated to be 40 months versus 26.9 months. And again, we're very familiar with the potential side effects of all of these different therapies, including the ILD that can occur in a fraction of patients, but usually of low grade. And then more recently, we saw the publication of the Patina trial in the New England Journal of Medicine. And this was a strategy that looked at patients who were both HER2 positive and ER positive, who started on a chemotherapy dual HER2 strategy. And then if responding, they pivoted to endocrine therapy or endocrine therapy plus palbociclib while continuing the HER2-directed therapy. And this was also a very important study that demonstrated that median PFS improved by a significant amount from 29 months to 44 months with the expected side effects that we see and are familiar with respect to the CDK4/6 inhibitor palbociclib. And then finally, the HER2 CLIMB-05 trial looked at the utility of adding tucatinib to a maintenance strategy. And the trial, again, started out with an induction phase, followed by response, at which point patients either continued on the HER2-directed therapy they started with or the addition of tucatinib. And this also demonstrated an incremental improvement in PFS of about 8 months. And we'll talk about some of the individual side effects that we might expect. And with that trial, there was a small fraction of patients who experienced cardiac problems as well as liver drug-induced liver dysfunction. And there are also some other trials ongoing. We don't have data from them yet, but the HEREDERA trial is looking at the incorporation of one of the newer SERDs into a population with ER-positive and HER2-positive disease. After they stop the induction phase, they would either get HP with giredestrant or not. And the ANOVA 122 trial is looking at the addition or not of inovolisib, and then, of course, endocrine therapy if the patients are ER positive. So these are strategies for incorporating targeted therapy into a maintenance approach. The latter two we don't have any data from at this point. So let's just try and get a sense of what you understand as we go through these data. This is instant recall from my comments 30 seconds ago. Which rare but serious adverse events were seen with the maintenance tucatinib and anti-HER2 therapy in the HER2 CLIMB-05 trial? So cardiac failure, ILD, drug-induced liver injury, or DILI and ILD, or cardiac failure and DILI, or DILI only. And again, it looks like most folks are picking the correct answer, which is a low frequency, but real fraction of patients that can experience drug-induced liver injury as well as cardiac failure. Not a high fraction of patients experience this, but it can happen. All right, so I'll pass the baton to Dr. Mizell.
Excellent, thank you. And that was a wonderful overview of some of the new and exciting options for patients in first-line maintenance therapy. So as we're choosing between these different options now, one question that we ask is, how do safety profiles and patient-specific factors impact these first-line maintenance therapy plans? And there are a number of things we have to think about. I think disease burden certainly matters. Degree of hormone positivity and HER2 positivity also matters. So for example, if you have a patient with strongly ER/PR positive disease and a HER2 2+ with a FISH ratio that's sort of just over the border for positivity, and the patient has bone-only disease, then you might really be strongly leaning more towards a patina-type maintenance regimen. Whereas if you have a patient that is hormone negative, strongly HER2 positive, and has a higher amount of disease in the liver, lung, or even brain, then you might really be thinking strongly about the tucatinib-based HER2 CLIMB-05 maintenance. So I think there are a lot of different strategies that we can use here, and it's nice to be able to personalize treatment a little bit more. And I think certainly age and patient fitness, we have to take that into account as we're thinking about how much treatment a patient can tolerate, and safety concerns. I think it's always nice to sit down with a patient when you first meet them to sort of go through the options, talk about what their past medical history looks like, what their day-to-day life looks like, and what are the things that scare them the most about therapy, because I think you can really get a lot out of those questions, build a lot of trust as you talk those things through, and then come up with the right option for your patient. Pill burden, I think, also matters. Definitely with either the patina regimen or the HER2 CLIMB-05 regimen, we're talking about an increase in the number of pills patients are taking every day. So coming up with strategies to help patients comply with those medications at home, and to make taking those pills easier for them certainly is an important aspect of this. And then I think, because we now have multiple options for patients, that shared decision-making becomes even more important. And I think, we hear that term thrown around a lot, but it really is important. And I think bringing patients into the conversation, making sure they know that even though you are the one with the expertise, they are in charge of their body and their care, really is important, and I think makes patients feel most comfortable. So, I think the important things in those conversations are to outline all the options and discuss with patients what their goals are. Ask some of those supportive questions. What matters to you? What are you afraid of the most? Is there anything that I should know about you to help me take better care of you? All of those are things that you can ask and really get a lot of information from patients while at the same time establishing trust. And, honestly, it's very efficient in our busy clinics to kind of do both things that way. I think addressing patient concerns about safety is really important. Some patients may have heard through chat groups or online certain things, like, for example, about neutropenia with palbociclib or diarrhea with tucatinib, and making sure patients understand what that actually looks like and what you would do to address those side effects can be really important. And then providing clear recommendations. I think a lot of times if you sort of throw some options at a patient and ask them to make the choice, that's not quite fair either, because they don't have the expertise that we have, and they haven't had the chance to go through the data or look at things objectively, nor do they have the experience of seeing multiple patients go through something like this before. So I think it is important and appropriate for us to go ahead and provide clear recommendations for our patients so that they know what we would recommend, but of course let them know that ultimately they're in charge and we'll support what they decide they want. So this is a question about monitoring. What are some of the best practices for treatment monitoring with emerging first-line maintenance regimens? Because with all of these regimens come, of course, different toxicities, and we have to think about how we're going to watch these patients. So certainly, every time we see these patients with each cycle of chemotherapy or targeted therapy, we're assessing what their symptoms are and addressing those symptoms. We're checking a CBC and a CMP. We're getting their weight. We're evaluating their ECOG performance status and seeing whether that's changed. If patients are getting chemo or targeted therapy, we're doing this pretty much with every cycle. With endocrine therapy plus a CDK4/6 inhibitor, every 1 to 3 months, usually monthly when patients start. In my practice, I see them and evaluate these things. And then once I'm sure that they're stable on the regimen, every 3 months is appropriate. And then scans, I think, also certainly appropriate in the metastatic setting, whether you do a CT scan, chest, abdomen, pelvis, and bone scan, or do a PET scan. I think some of that can be regional and can be provider preference. Usually doing those about every 3 months is appropriate, but as patients are further out in maintenance, which we may see more of now, I think it's appropriate to lengthen the duration of time between imaging tests, using shared decision making to make that choice. I think for a lot of patients, there may be some scanxiety involved. They may prefer to have fewer scans if they're feeling well, and potentially monitor tumor markers more often, which is certainly reasonable, especially if their tumor marker was higher at baseline. So I think that you kind of use some of those shared decision-making strategies to help with your monitoring as well. And then brain MRIs are an interesting question. Historically in breast cancer, we have not done brain MRIs at baseline unless patients have symptoms, or to monitor at follow-up. But with HER2 positive metastatic breast cancer, because patients do often, have brain metastases that can be treated in various ways, both with radiation therapy, of course, but also with some of our targeted therapies, we often will get a brain MRI at diagnosis to see if brain metastases are there, and then certainly at each progression to see if there's progression in the brain as well as in the body. For me, I'm mostly not doing brain MRIs unless a patient has a known history of brain metastases on that baseline MRI or is progressing systemically. But some people will choose to do those a little bit more often. So we can talk about that more as well. And so then the next question of, how do we monitor and mitigate adverse events with these novel regimens? So we're watching patients, we're giving them these novel maintenance therapies, many of which are pills, and so require patients to take their pills at home and discuss these things with us. What is the best way to monitor for these and to do everything we can to mitigate? So, one of the things is CBCs. So the Patina trial, of course, with palbociclib, one of the most common side effects that we see is going to be neutropenia. So the recommendations are to monitor that at baseline, the beginning of each cycle, and then on day 15 of the first 2 cycles. And then if neutropenia is grade less than 3 for 6 cycles, you can extend that monitoring interval to every 3 months. So basically checking every 2 weeks for the first 8 weeks, after that monthly, and then at cycle 6, so 6 months in, you can extend that to every 3 months. And then in terms of managing neutropenia, if you have grade 3 neutropenia or higher, then you're going to withhold treatment on day 1. And then when it recovers to grade 2 or lower, you can resume at the same dose. The caveat to that is if the patient has febrile neutropenia, which is rarer, but we do see it sometimes, then you withhold at any time. When the patient recovers to grade less than or equal to 2, you resume at the lower dose. And doses in Patina were the same as the doses that we're comfortable with in ER-positive metastatic breast cancer, looking at 125 milligrams as the starting dose, and then 175 being our dose reductions. So testing your understanding, and similarly to the first testing question, this is kind of looking at the question I just asked and answered a little bit. So checking to see if you're paying attention. You've got a 62-year-old woman. She has hormone positive, HER2 positive metastatic breast cancer and receiving the patina regimen in the maintenance phase after induction. In cycle 2, she develops grade 3 neutropenia without fever, important point, or infection. In addition to monitoring her ANC daily, what is the most appropriate next step? Are you going to continue palbo at the current dose and initiate GCSF? Are you going to hold palbociclib, resuming at the same dose if the neutropenia recovers to grade 2 or lower within a week? Are you going to hold the drug and resume at a reduced dose if the neutropenia recovers? Or are you going to permanently discontinue palbociclib and continue the anti-HER2 therapy by itself? All right, excellent. This is a tricky one. I think the key is that this patient is neutropenic, but she does not have a fever. And that's going to impact which dose that you choose to resume at after you hold. So typically in this situation, what we're going to do is we're going to hold the drug, we're going to recheck, and then if the patient resolves, the neutropenia resolves to grade 2 or lower, we actually can resume at the same dose. If the patient had febrile neutropenia, then we would want to resume at a lower dose. So hopefully that makes sense. Perfect. So what about tucatinib? So we'll move on now just to talk about, sorry, these slides are jumping around a little bit, to talk about elevated liver enzymes with tucatinib and anti-HER2 therapy. So this was one of the more commonly observed side effects in the HER2CLIMB-05 trial, thankfully mostly low grade, but definitely something to watch for. So we monitor ALT, AST, and bilirubin at baseline and every 3 weeks, and use that to sort of help us, especially if those are elevated a little bit, to assess for drug-drug interactions. I think more and more patients these days are taking different supplements. They don't always tell us exactly what they're taking, but if we see that these numbers are up, we just want to make sure that patients aren't taking anything else that could be impacting them. And then if patients have grade 2 bilirubin elevation, we're going to hold until they recover to grade 1 or lower, and then resume at the same dose. But if it's grade 3 or grade 4 bilirubin, or the AST and ALT are elevated, then we have to act a little bit further. So if it's grade 3 bilirubin elevation, we're going to hold until it recovers to grade 1 or lower, and then resume at a reduced dose. If it's grade 4 bilirubin elevation, along with ALT, AST, then we permanently discontinue the medication.
Yeah, and I think
Hopefully that makes sense.
I'm brown, so I'm gonna keep going. Or
Yeah,
orange.
go for
I
it.
shouldn't say I'm brown. I'm orange. So again, let's look at some of the other side effects. Diarrhea happens in a fraction of patients, and that can be a function not only of the HER2 therapy, but also sometimes, related to tucatinib, depending on which regimen you're using. So one of the things that always is important to make sure patients are compliant and adherent is addressing any of the side effects that occur, because if they're not taking the medication or taking it inaccurately, they're not reaping the benefits. But at the same time, if they are experiencing a lot of side effects, their enthusiasm for continuing might diminish. So early intervention with antidiarrheal medications like loperamide and making sure patients stay hydrated and electrolyte replacement is important. There's occasional, again, it's rare, but severe diarrhea, something that requires hospitalization, where you can get significant kidney dysfunction, and even death have been reported with tucatinib. But I want to emphasize that this is not common. So if diarrhea is occurring, you hold, and if the diarrhea persists for more than 48 hours, or you're seeing more than 7 stools per day over what you would see baseline, you would hold the tucatinib and resume it once the toxicity had decreased to less than or equal to grade 1. And if that happens, then you can resume at the same dose if no prior antidiarrheals. But if you were using antidiarrheals to control the symptoms, you may have to dose reduce. And similarly, if you're not seeing the desired effect by maneuvering the tucatinib, you may also have to modify the pertuzumab dose, which can also be responsible for diarrhea in some patients, or at least loose stools.
Excellent.
And then again, the other thing that can occur in some circumstances is nausea. And if you look at the maintenance regimens that we're talking about, that either contain palbociclib or tucatinib based on the patina, the HER2CLIMB-05 study, Again, these are drugs that aren't commonly associated with significant nausea. It can occur, but it's not common. But if you are having patients complain of that, then of course we can use very commonly used antiemetic regimens, dexamethasone, metoclopramide, pyrazine, and other drugs that we commonly use in the clinic for other indications. And again, we can always add things if the regimen isn't being tolerated. Olanzapine is particularly effective in some patients. And again, we have to think about dose modifications if you're experiencing persistent or high-grade nausea. And again, I want to emphasize with these drugs that we're talking about today, that's generally pretty uncommon. And this back to Jane.
Perfect. So we talked a bit about side effects, and now I think, diving into the multidisciplinary team, it is really important, especially in these patients on pill-based maintenance therapies, that the multidisciplinary team is involved in managing these patients. Because unlike with IV medications, a lot of this success of the patina and the HER2 regimen revolves around patients taking their medications at home, and so making sure they understand how to take them, making sure they can afford them, and making sure that if they call in with side effects, the right people are talking to them. It really makes a huge difference in terms of compliance and patient tolerability. So I think having a pharmacist or someone in that type of role who can review the regimen with the patient, do a follow-up phone call 2 weeks after treatment initiation if possible, just so if the patient's not seeing a provider during that time, they've got someone they can report into about side effects and about things that may be going on. Similarly, because these medications can be expensive, it's sometimes helpful to have a social worker or a financial counselor who can help navigate cost barriers, if there are appeals that have to be filed to get the drugs and things like that, to make sure patients get them in a timely manner. That is really critical also. And then to make sure that our nursing team is aware of some of these common side effects, neutropenia, diarrhea, nausea, and aware of some of the main things that we do to manage them, so that if we are not immediately available and a patient calls in with something like this, a nurse can give patients some initial guidance and then let us know what's going on so that we can then continue to help manage the toxicity. But I think this is great and a really nice option to empower the whole team to help manage these patients so that they have the best outcomes and feel supported. So that really kind of brings us, I think, to our Q&A, right on time, and we're looking forward to answering your questions.
So if anyone has a question, please feel free to put it in the chat. And we have one. How would you approach treatment selection with these maintenance strategies versus TDXD with pertuzumab? So I guess that's a good question. And you sort of address that a little bit, particularly if you had a patient whose disease was principally bone only and happened to be ER positive. That may be a strategy that it sounded like, Dr. Mizell, you were more interested in the patina-like regimen for that kind of patient.
Yeah, no, I think so. And I think then the other question that comes up, and I think this question is touching on this with the TDXD pertuzumab, because with Destiny Breast 09, that was done sort of indefinitely. And so how do you choose which patients, if any, really need TDXD pertuzumab indefinitely versus switching after a certain number of cycles to a trastuzumab pertuzumab plus either patina or HER2 strategy? And I think we're still learning a lot about that, and there will probably be some information that emerges over the years about which patients are best for which strategies. I think sometimes it can be complex and hard for patients to give TDXD indefinitely as first-line therapy. So I do like the idea of a limited number of induction cycles, and then for most patients, switching to one of the maintenance strategies, kind of using some of the principles that we laid out.
Yeah, and I suppose using TDXD to maximum response would be another strategy as opposed to fixed. And then, the other thing that I'm curious about, just your own sense of things, HER2 with tucatinib, of course, tucatinib has its own set of side effects in your mind because there's obviously no direct comparison. How do you think about HER2 versus TDXD plus P, sort of just continuing it with respect to toxicity profile?
Yeah, it's tricky. I think, my own experience with tucatinib has been that it doesn't in the maintenance setting, and we had the HER2 trial open here, and I did have patients on it, that it doesn't add a whole lot of toxicity on its own. I mean, the LFT thing is real, but I found that most of the time when I'm giving tucatinib and patients have diarrhea, it's along with capecitabine, and then if you dose reduce the capecitabine in that later line setting, patients do well. So I tend to think of HP tucatinib being sort of a less difficult maintenance strategy for most patients. I think because many patients will do well with that kind of strategy, and with TDXD, you do see about 10 to 12% pneumonitis if you treat for long enough. I think for the right patient, the HP2 catnib strategy could be a better tolerated one in the maintenance stage.
And I guess a corollary of that is if patients did make that switch to tucatinib after undergoing induction therapy, and at some later time, they did develop disease progression, one could revisit the idea of TDXD again because
Absolutely. Yeah,
they
I think
hadn't
that I
exhausted
feel
it.
that way too. If you treat to either, a fixed number of cycles or to maximum response with TDXD as an induction strategy, and then a patient ends up on some trastuzumab, pertuzumab based maintenance with pills for some longer duration of time, a year or more, I would absolutely think about reintroducing TDXD as a second line option.
In a different subset of breast cancer, ER positive, we've been sort of intrigued by the Serena-6 data that
Hmm.
suggested you could look at ctDNA prior to any evidence on a clinical basis, meaning scans that the disease had progressed, and then make a change of therapy based on that. But in the HER2 positive space, are you using ctDNA in that kind of way?
I haven't been. I think one of the things that I would potentially consider if I had a new HER2 positive metastatic patient that I was considering starting the TDXD pertuzumab strategy would be potentially monitoring ctDNA, because that might help me figure out, especially in a patient who's having side effects, when I would feel most confident switching to a maintenance strategy. And I do think there will be some studies that will sort of bear out what the role of ctDNA might be in this population. So I think it potentially will have a more straightforward role going forward.
Okay.
What do you do in this
No,
situation?
I haven't been doing that in this subset of breast cancer, or and I guess even more broadly, I haven't adopted the Serena-6 even in
Yeah,
ER positive disease yet, but I think it's a direction we're likely to be going
yeah,
if we can have confidence in the results.
yeah. No,
Another
it seems to
question.
make
Go
practical
ahead.
sense.
Go ahead.
No, I was just going to say it seems to make practical sense that having that strategy available to us, and especially as more data comes out, that will probably become more of a mainstream option.
One of the questions, or a couple of questions, focus on patients with HER2 positive disease and brain mets. And I guess the starting question would be, does that sway you in terms of which one of these strategies you might use? TDXD, we know, gets into the brain. Tucatinib gets into the brain. Are you attracted to one recipe versus the other?
I think I would definitely, if I have a patient with brain metastases at diagnosis, I would be very excited about the TDXD option as induction for sure. And I think the question of how long to continue that, certainly you could monitor ctDNA, although we don't have exact data to guide how to do that. I also probably would want to see how the patients are tolerating the TDXD to see how long I would continue it. But I think, for many patients, doing TDXD for, years could be challenging. And so if that patient did do well for a long time on TDXD pertuzumab induction, that would be someone that I would consider a switch to HP tucatinib maintenance if the TDXD became difficult to tolerate.
Yeah.
But I think we are fortunate now to have both of these drugs that cross the blood-brain barrier and can be very effective in this population. I remember starting at Emory and seeing brain metastases at that point was really, almost a death sentence. And now these patients can live for a long time. So it's encouraging to have these options.
No, I agree. And I think between therapies that can cross the blood-brain barrier that we didn't think could cross the blood-brain barrier before, big molecules, as well as selectively using stereotactic radiation therapy rather than whole brain in certain circumstances, we can maintain quality of life, and just their functional status for an extended period of time. So I think it is an advance.
Absolutely.
I'm just trying to see if we have any other questions that we haven't addressed. I'm not seeing any. So unless there's a last minute addition to the list, I think we have gone through everything that people were querying us about. And I want to thank Dr. Mizell for sharing the task today with me, and for everyone who participated for their questions. You can download the slides from today's session, and you can go to the website that's listed here, and there'll be a multimedia version of the other parts of this, because there were two other parts that have been put together dealing with other aspects of HER2 positive breast cancer. And any other information you want can be directed to the email that's listed on the slide. So with that, I want to thank you. I hope the rest of you have a great day and hope to see you down the road.
Wonderful. Thank you so much.
Thank you for listening. Please visit the activity URL in the episode description to view all program materials, complete the post-test, and get a certificate.